so really, when we started this work, we wanted to see what the potential for AI is within the existing systems, knowing that both Aegis and Gemini Afia have had great success at the national level in Kenya and in Zanzibar, and are being used by hundreds, in some cases thousands, of CHWs for data collection. And also knowing that it has been a journey to adopt digital in community health. And so even introducing new innovations like AI is still very new, very exploratory. And I think when we were going into this research, we were really going in with a mindset of curiosity and learning as well. And so through this work, we've been able to document a lot of really great insights. We'll discuss some of them in this presentation, but if you are interested to learn more about our work, you can always reach out to us. So if you can go to the next slide. So this work really took a human-centered design approach with really thinking about the user at the center of the work and taking a very community-centered and community-driven work. And what that meant for us is that we were working with the full breadth of the ecosystem, the community health ecosystem, to identify and explore AI solutions. And this means that we weren't just going in as observers, we were really going in as collaborators and partners and building relationships with community health workers, with local government, with national government, to really ensure that whatever solutions come up, whatever ideas come up from research, they are inclusive and responsible, knowing that AI is still an area of innovation that is very new within the continent, but also knowing that there's still little that is understood about how this type of innovation can interact with different types of users. We also came in with a very open mindset around contextualization, knowing that we see CHWs as experts in their own right. They are the ones who know their work the best, but also their contexts are not homogeneous. They are very different. They vary in everything from the language that is spoken, the health services that they're providing, the workflows that they're using, the programmatic protocols that are applied within their context. And so there's such a wide range of contextualization that needs to be understood when going into design for a digital solution that is already been used. And so we took a very iterative approach that started with working very closely with national and local governments. So this would be the ministries of health, the county government, the district government in Zanzibar, to define what we see as a very broad and overarching challenge that we would want to address. And in some of these conversations, I think it was really helpful to hear how the journey of using and adopting Aegis and Gemini Afia in the two countries has been. Because this journey continues to be very important as the digital solutions continue to evolve, as use cases are added to the platforms, as there are continued design considerations that have been made, improvements and so on. And there are questions about data use as well, and data capture. And so those conversations really anchored us in a reality of where we need to start. And that's how we defined a research learning agenda, was through that experience. And I think when we were defining the research learning agenda, we were also seeing ways that we can explore aspects of behavioral design in everything that we do, knowing that I think human behavior is very unique and sometimes not predictable. And so what are some of those behavioral personas and levers that we can anchor on that can help us design use cases that are quite specific to the behavioral and contextual traits of community health workers and their ecosystems in these communities. And also working with the government from the beginning was important because it helped us to get the buy-in that we needed to move on to the next stages. And so the next stage was this exploratory research. In some ways, it felt very foundational because we were trying to define things that, or rather, we're trying to define like what is AI and what can AI do, but at the same time, trying not to start with the technology, but rather identify what are the things that can really help community health workers, community health supervisors in their existing roles. Where can they be efficiencies that can be built in? Where can things be improved? Where can health service delivery be improved? Knowing that at the core of community health is really this commitment to serving communities. There is a long history of trust that is built with community members. And also there is really a badge of honor that CHWs carry in doing their work. And so in thinking of all of those things, we did research in Kenya, in Machakos County, and in a few districts in Zanzibar. Sorry, if you can go to the previous slide. The previous one before this. Again, one before this. Yeah. And so I just wanted to finish what this process looked like. So after the design research, then we went into identifying the use cases and solutioning. And we did do quite a bit of prototyping. And like I mentioned, we took a community-centered approach, which meant that we worked with communities in a very close way. And we realized that the best way for us to bridge our knowledge gaps with what the community is doing is to identify user champions. And so we identified user champions who are a combination of CHWs, supervisors, in some cases even government workers. And there was a small group of individuals who were supporting in testing and validating our use cases. And so we would engage them routinely as we were coming back and synthesizing the use cases and really trying to establish whether we're on track or not. And so engaging the champions was really useful in validation, but also helpful in introducing these use cases back into the community. And we'll share a bit about how we did that use case design, prioritization, and then design of the actual solution and innovation. And now we're sort of in that last phase where we have built the innovations, we are in the process of piloting them, and really excited to see what the potential can be for this work. Next slide. So I've already talked a little bit about user research, so we can go to the next slide, which is about the research methods. And this has been, the research methods is really critical. Sorry, if you can go to the next slide. We used a combination of co-design activities. Like I mentioned, we worked very closely with the government and all across in all of our activities, we had touch points where we would engage the government in our processes so that they can validate our use cases as well as give us the necessary buy-in we needed to move forward, but also for them to believe that this work is meaningful, for them to believe that this work is actually going to result in some sort of impact. And so there were a wide range of participatory methods, from in-depth interviews to focus group discussions, to workshops. We also did an audit of the existing digital platforms to see the availability of data to be able to sit on a potential AI innovation. So quite a bit of participatory activities went in. And while it did feel the investment in research for us is really important, because without all of this buy-in, without the participatory engagement, without the contextualization, but also without the permission from communities to enter their spaces and do this kind of work, it's very challenging to be successful. So these are the locations that we did research in. So in Zanzibar, we were in Unguja, and in Kenya, we were in Machakos County. And you can see there was a wide range of stakeholders that were engaged. And if you can go to the next slide, I think for us, what has been really interesting is the process of surfacing use cases for AI, which within the design and product development cycle has been an experience to learn what does that actually look like? How do you come up with an AI solution? And really for us, it started with quite a bit of, like I said, design research and primary research data, and taking all of those qualitative insights and actually translating them and synthesizing them into tangible use cases that can then come together into a cohesive solution was a really exciting process. And I think one that has shown us the importance of this type of solution development. If you can go to the next slide, one important step in identifying the right solution was coming up with a prioritization framework that looked at both the tech feasibility as well as the impact and value addition, which are factors that we felt were the right criteria to establish which of the long list of use cases that emerged from research, which of those would be the most viable to move forward with. Because of course you can't build everything. There were so many exciting things that came up. But I think based on the way that we prioritize, we felt that because this is very much a foundational project and a foundational innovation, that initial proof of concept is something that should be as simple enough that it can grow into something and that is truly incredible and remarkable. And we see that a lot with these types of digital health solutions. When you do start with something that is simple, it really grows into something that feels scalable and attainable. And also knowing that the adoption of AI solutions is costly, it's important to put those considerations into place. And so we did have this prioritization framework. If you go to the next slide, you'll see the next part of the framework, which is the value addition and assessment that looked at a number of factors. And so if you go to the next slide, this shows you, and we're using the AMREF example here, we identified 7 use cases from our research with community health promoters and supervisors in Machakos. And from those 7, we mapped them against this prioritization framework. And you can see that the 7th one is the one that prioritized the highest in terms of what we can adopt immediately. And the interesting thing about this particular use case is initially we had envisioned that whatever innovation we are coming up with, it will be an innovation that is will be used by CHWs. However, this particular one is actually a supervisory tool that is helping community health promoters, supervisors, to get real-time data for decision making. And the reason why this was critical is because there was a bit of a spiraling effect that we were seeing with issues related to reporting supervisors and CHWs. And what that spiraling effect is, we had quite a bit of feedback from the supervisors that they were not able to see reports or get them on time. And some of these things were platform related, but a lot of them were really decision related. And it really made us think about what are some of those isolated decisions that supervisors are looking to make, and they don't necessarily have the right combination of data to make those decisions. And so we really anchored on that because we saw that if supervisors can really change their behaviors around how they're using data for decision making, then this has an effect on how their own CHWs, whom they're supervising, can be able to change their behaviors. And so we're really taking a behavioral lens to this work, but we were also taking a pragmatic approach in terms of what can we start now and scale outwards. But also one important thing that came up was the solution we have right now is not currently within the Aegis platform or even the Gemini Afia platforms. It's sitting outside of the platforms. And that is intentional because it is a proof of concept, and we're using this as an opportunity to test and get as much feedback as possible, and then see how we can move towards integrating into the existing platforms. And so if we go to the next slides, yes, so the next two slides are the actual use cases that we landed on. And I'm going to invite my colleague Joy, who's going to walk us through the two use cases.
Thank you, Aika. We're going to shortly see a demo of this particular use case, but I'm going to just quickly voice over what we designed and developed for Kenya and Zanzibar. I'm going to start with the first use case we prioritized for the Kenyan context, and this was co-developed alongside AMREF Health Africa. It focuses on community health assistants who you may hear me refer to as CHARs. CHARs play a very critical role, as Aika mentioned, in supervision and data quality at the community unit level. They are the supervisors of community health workers in the Kenyan context. During my immersion, when we spent time with CHARs in Machakos County, one thing that came through very clearly was that their biggest challenge was not that they didn't have data, but rather it's that they were overwhelmed by it. A lot of the CHARs we spoke to are supervising dozens of community health workers, and this is often across multiple community units. So to give some context, you'll see a single supervisor in Machakos typically supervise about 5 to 7 community health units, which easily translates to up to 70 community health workers that they're expected to support and oversee. In addition to that, they're responsible for validating monthly reports, mentoring the health workers, following up on referrals. And with all this, they're also trying to understand what's actually happening in their community so that they can improve health outcomes. What we learned from our time with them there is that the way the data is showing up today is making all those tasks very hard. So Aika mentioned earlier that data sometimes will come in late. This is largely because of limited connectivity or access, but it also comes in fragmented. So sometimes they're getting data through the Aegis platform, or sometimes through WhatsApp or calls, and sometimes even on paper when the system is down. So because of this, before monthly reports are submitted, what we were observing is that CHARs are spending a significant amount of time manually scanning for errors or reconciling data from the multiple data sources, doing mental calculations, and a lot of them are even calling the community health workers to confirm numbers. So a lot of their time was being spent just before the end of the month trying to figure out if the data they're about to submit for national reporting is actually data that they can trust. So they were rarely even giving thought to things like what that data could tell them about the needs that they need to, what needs need to be done to improve health outcomes in the area of supervision. So this is where this use case came in. The AI-powered reporting assistant is designed to sit just before that report submission period, which is usually before the end of the month. And it does a kind of fast pass work that currently is sitting with the supervisors. So one, it will look across all the community health workers' data within a community unit and highlight potential inconsistencies. Just to note here that this is not to replace the supervisor's judgment.
Time
Sorry?
check.
Okay.
Time check. you can wrap up in the next 2 minutes before we transition to the demo.
Yeah. So some of the key features, the CHP data is being used to highlight potential inconsistencies. I was just mentioning that it's not to replace the supervisor's judgment, but it's to focus the attention on where follow-up actually matters. So you'll see in the demo, for example, that the reporting assistant can flag values that don't align with expected ranges, or immediately show how many community health workers have not synced their data and which ones haven't. So it also produces a simple community unit level snapshot of emerging health trends in the community. So you'll see things like maternal health gaps or rising cases of non-communicable diseases shared. And again, all this is leveraging data that community health workers are already collecting during household visits, but were not using meaningfully. And lastly, supervisors can also interact with this AI assistant through WhatsApp, which is a very familiar channel for them, using open-ended queries. So they could ask very practical questions like what health issues are coming up often this month, or which community units have the most incomplete submissions. So all these mirrors are very natural, chatty way that they already communicate and work. And in essence, what this solution is doing is that it's not trying to make CHAs more data-driven. They already are. It's trying to reduce that invisible labor of supervision so that their time and attention is now going back to other equally important things like mentoring, problem solving, or engaging with communities rather than just chasing numbers. So you'll be able to see this assistant in action shortly through a demo by my colleague Medrin. The next one is around, if you go to the next slide, this was forecast in Zanzibar. Just to quickly highlight what happens here, it focuses on a very specific moment in supervision workflows. And this is the monthly CHV meetings where supervisors and CHVs come together, and community group sessions where CHVs sensitize community on key health topics. One of the things we had during the research in Zanzibar is that supervisors really want these community sessions to be useful, and they want them to be aligned with the things that people in the community are actually experiencing. However, practically choosing those topics is not straightforward. In practice, what used to happen is that topic selection depended on whatever information was easiest to access. So it could be through word of mouth, it could be what CHVs were reporting back during those monthly meetings, etc. So the problem we're addressing through this AI tool is very simple. It's around using the data that they're already collecting to empower them to get timely data-backed insights on pressing health issues in their area so that they can guide CHVs to run more relevant and impactful community sessions. Three key things here just to highlight. The AI solution was providing the timely data-driven health insights. So, for example, the tool might surface cases of childhood diarrhea that have increased across households in that month and sent to a supervisor via WhatsApp as a suggested topic for the community sessions. It was also supporting not just the health topics, but also generating a draft session agenda for those community meetings with key talking points or FAQs related to the health topic, and also giving them supportive training materials to use during those sessions. Again, this was also delivered through an accessible channel like WhatsApp. So supervisors receive and use these insights through a tool they're already familiar with. And especially in the Zanzibar context, again, language here was critical. So all this information was being shared through Swahili. With that, I'll hand over to Medrin for the demo of the first use case, where we'll see how these tools work in practice. Over to you, Medrin.
Thank you, Joy. I will take over from here. Okay, so I'll start very briefly with what a supervisor sees
what a new supervisor sees when they first interact with the chat AI assistant. So remember, this is in the Kenyan context, and that's what I will be demoing. So when a supervisor opens the assistant, it first introduces itself and it explains what it helps with. So which is the tracking the community health promoters, who you had are the ones who go door to door, so the CHPs, and understanding the health concerns. And then it immediately checks that it's working with the right community health units. So this confirmation step is very important because it ensures that everything that follows this conversation is very specific to the supervisor's catchment area. So after they confirm the details, the assistant does two things very clearly. So first, it shows the supervisor what they can achieve with the assistant. That's the first 3 bullet points. Then the next thing it does, it sets expectations out upfront. So it tells it flags where the data comes from. And in this case, it comes from HS, which is where all this data is recorded, and that it is here to guide, not to decide. So remember, the assistant is a tool and not a decision maker. It just helps you. It helps you with the making of the decision. So from the very start, the assistant is clear with about what it can help with, and it makes sure that this data is grounded. It's correctly grounded with the right data. So given that we have limited time, I'll go to a pre-recorded chat we had before. So I'll focus on the tangible value a supervisor gets from this. So let's move to a real scenario. It's nearing the end of the month, and a supervisor wants to understand what has been happening across their multiple community health units before they meet with their community health promoters, the CHPs. So at a high level, the supervisor can quickly check how their allocated community units are performing. So here we can see that all the CHPs, in this case, have synced their data, meaning they've gone and actually done collection of data. However, it also flags that the number of households that have been visited in this period has gone down. So this immediately flags the supervisor that they might require a follow-up. So maybe they can check on the different supervisor to remind them to complete their household visits. And then the next scenario will be the health trends. So this sorry. So the next view is the health trends. So here, supervisor sees that there is rise in the underage deliveries. So they're given a few trends and they can ask for if they want. So underage deliveries, but not just number, then ask questions to dig more into it. So instead of asking and trying to figure out by making calls and all that to understand what is going on, they can ask to learn more. And in this case, once they ask to learn more, the assistant surfaces relevant reference materials that the community health assistant, the CHA, can use to prepare and learn more. So these documents are from the Ministry of Health, and they already use them with people. So it also helps highlight why this trend is an actual
Medrin, your internet
in a
is
very summarized way.
Medrin, you are dropping off.
And it actually appears here. Back. Hello? Am I back?
Yeah, we were not getting you clearly for the past 1 minute. Could you just repeat what you're saying?
Okay. I'll just quickly go through. I'll quickly go through what I'd do a quick recap. So when the supervisor asks for health trends, they're shared for several health concerns, and from this they can just see they're highlighted on the chat, and they can always ask for more at any point. So they can click on additional trends and they can get more. So once they say this, they can be able to click and double tap on a certain trend. So in this case, we wanted to learn more about the underage deliveries. So what happens here is the assistant shares a document with the CHA, and this document is verified by the Ministry of Health. So they already use them, and they act both as a reference material during their own readings, and they're also used during trainings. So it also highlights why this trend is important. So they can always click on it. It opens up, and they can go through the actual material. And then it also highlights why this trend is important. And it also tells them what gives them points as to what they can discuss during the community meetings. Another thing it also does is, remember, there are trainings they do with the community health promoters. So the monthly meetings they have with them, it also highlights to them and gives them discussion points that they can bring up and reference the material to give it more meat, if I may say. So there's also a note there telling them that these are only guidance points. So through and through, it's emphasized that the decision always lays with the community health assistant, not the bot. So a supervisor can explore the other trends in the same way and request more details when needed. So each one of them follows the same flow that we've just seen. So from a supervisor's perspective, who is our CHA, this really changes how they work. So they can quickly see what's changing. They can understand what each could mean from the discussion points. And they're also better prepared when they're supporting their community health promoters. So this helps them have more targeted and more intentional meetings and discussion points with their community health promoters. And a few points. Remember, at the end of the day, all the data that we share, everything that is happening in the community health, the CHA AI assistant, is based on the data collected. So it is not guessed or taken from anywhere. It is based on actual data. And then at the end of the day, as I said, we try and make it very apparent that the final decision always lies with the community health assistant and not with the bot. So that's how the supervisors use it. I'm happy to stop there, and I'll pass the mic back to Ika. I'm sorry for the small technical hiccup.
No worries, thanks. Oh, before Ika comes in,
Okay.
any questions from community members? Yeah, I saw an input from Jason. Would you like just to voice that?
Yeah, hi everybody. It's Jason Burke here from Western Cape Department of Health. I just wanted to echo and say that it's very nice seeing a very realistic analysis of the feasibility. A lot of AI projects, especially at the moment, are very overly optimistic. So I'm actually very encouraged to see you testing out 7 possibilities and throwing away 6 of them, and only going with the one that's actually looking good. So yeah, good job on that.
Right, thank you. I also saw Abbas from Zanzibar. I'm not sure if you have any thoughts or input to share in regards to this work. Abbas, are you still around?
Hi, Anton. Hi, everyone. Sorry, could you pardon?
Yeah, I wanted just to hear if you have any thoughts or feedback to share in regards to this work you are working on with Dalberg.
Yeah, so the generative AI assistance has been so effective here in Zanzibar. It has reduced the number of hours the community health care supervisor were using in terms of preparing the monthly agendas, but also how they tackle different issues related to the health trend based on their catchment areas. So it has helped them to automate their workflow, but also providing them uniformity in terms of how they are conducting these monthly check-ins with their community health workers, but also enable effective training and capacity building during this monthly session with the community health workers over time. So it has been very helpful, and we're looking forward to expand to other districts so as also be able to use the solution. Thank you.
All right. Thanks.
Hi, excellent presentation from Dalberg team. Great to see it. One quick question. Does the agent talk to the database every time, or there is some delay in that? And I would also love to see more detail in the technical stuff in the forum so that every community can also benefit and look at this if possible. Thank you.
To answer your first question, I've not heard your second question, so my bad. Please, maybe you can reiterate it. But on the first one, there's usually a 1-day delay. So remember, there's a lot of data that we are consuming. So what we do is every day, all the insights are delayed. They have a 1-day delay. So the trends run overnight, and then the assistant shares the information. So there's really a very small lag.
Okay, thank you. Yeah, I understand that. My second question was, if we could see more technical detail, probably we posted in the community forum, it will be beneficial for everyone, if that is possible and doable from Dalberg team.
All right. Thanks, Yuvraj. We'll follow up with them just to post that on the forum. Aika, could you take a minute just to wrap up on reflections?
Yes. Thank you, everyone, for your comments and questions. Would be happy to continue the conversation because, of course, the time was quite limited today and we were focusing mostly on the design process. And so if you have any questions about any other parts of the technical design or even programmatic aspects, please feel free to reach out to us, I guess through Anthony or through the community. Would be happy to engage with you. Really quickly, yeah, I think just some key reflections. And I imagine this will evolve as we continue to implement. I think for us, there are limitations in getting fully contextualized health information for each country. And so there is a need for local, good quality local data sets. And these really relate to some of the things that you've seen, background, contextual information on health trends and so on. Language is something that has come up as a really, really critical aspect of accessibility and trust. And so it was really exciting because the application in Zanzibar that D3 has implemented is fully in Kiswahili. So that is a really great contextual element. I talked about the community health champion. I think for us that was really critical. And then an evaluation framework. I think for us, because again, this is still quite foundational, we are looking for ways to strengthen the evaluation frameworks for this type of work that sits at the intersection of tech and health programs. So any suggestions on that are really welcome. And the importance of low-cost prototyping and iteration, which in many ways is really has a strong return on investment, particularly when you're working on government initiatives. Thank you so much, Anthony. I know we took much more time than you had given us, but thank you so much for the time.